that the role of the CIO has changed totally. You know, we were software developers and architects, and we could tell you what RAM to use based on its transactional speed. Do you think any of that matters anymore? The answer is no.
Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics.
I was the CIO for a 23,000 person health system, and one of the biggest challenges was to remain current on the technology and the trends that were going on myself.
Think of artificial intelligence as a orchestra. Right now, machine learning, deep learning is getting a lot of attention, so I sort of equate that to the string section. And obviously there are many sections to the orchestra, so someday soon, hospitals, healthcare organizations are going to be able to have amazing music.
We are seeing instances of folks popping up, us included, where we're having a primary care physician set up with the dentist in the same office.
I would love to get to the space where eventually we're using voice recognition to do all of our navigation throughout the electronic health record.
When we worked at Microsoft, oftentimes, you'd have crazy deadlines. People would say, look, we're not saving anyone's life here. We can't say that anymore. And we love that. It's like we can save someone's life. We can prevent a complication or a readmission by catching it.
A lot of the feedback people are hearing about former Vice President's remarks is that he was remarkably pragmatic. And then the one that I'm most excited about, he notes that the Medicare Innovation Center, which was created by the Affordable Care Act, has the legal authority to experiment with new models to engage patients for purposes of getting better value care.
Hyper-consumerism driving everything to a digital experience, because if we don't make it easy for patients like ourselves to use healthcare on our smart devices, companies like Apple are starting to do it for us.
I think we're right on the cusp of a huge digital transformation. It'll be interesting to see how CIOs sort of address that.
Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. This is episode number 49. Today we do a deep dive episode where we take a look at a decade of EHR implementations, probably longer than a decade, to examine what correlates to success and what doesn't. This podcast is brought to you by Health Lyrics. Health systems are moving to the cloud to gain agility, efficiency, and new capabilities. Work with a trusted partner that has been moving health systems to the cloud since 2010. Visit healthlyrics.com to schedule your free consultation. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics. From time to time, listeners of the show will recommend that I speak to someone or cover a specific topic. A recurring topic of conversation this past year has been the Arch Collaborative. I sat in on a session of the Chimefall Forum and took in Taylor Davis's presentation on this topic and knew that I wanted to have him on the show. So today's guest is Taylor Davis, the EVP of Strategy and Analysis with KLAS Research. Good morning, Taylor. Welcome to the show.
Hi, good morning, Bill. Thank you for having me.
Well, so many people have come on the show. Amy Maneker discussed it, and as have others who have come on the show. And it seems like you guys have done the research that we've all been waiting for and really wanted, which is what leads to success and what doesn't lead, potentially what doesn't lead to success that we're spending an awful lot of time on. So I really appreciate the work that you guys have done. We'll jump right in here. So the format of the show is usually we go back and forth on news stories. Today's a deep dive episode, which means we're just going to focus in on this one topic. So let's start with the basic question. What is the Arch Collaborative and why does it exist?
Well, Bill, you said thank you that we've dived in and worked on the research that we've all wanted. We've wanted it too. So KLAS is a research organization for a lot of years. Let me give you actually my personal experience. So I've been with KLAS for 12 years. I joined KLAS in 2007, early 2007, and watched the rise of electronic health records with, in 2009 through 2015, right?
Right.
And
So I've done thousands of interviews with healthcare leaders, with CMOs and CMIOs and CIOs, and it's common that we get on the phone with them and we say, hey, how are things going for you? And they say, well, we still are really struggling. A lot of people are really disliking our EHR, and we'd hear that about every EHR. And I'd have interviews with a passionate physician that say, well, Cerner's way better than Epic, and Athena's way better than Cerner, and Epic's way better than Athena. And I think I just broke a transitive law right there as I described that. But that's how it felt for us, right? Is we were hearing it from everyone else, and everyone was talking about, hey, it's the software. KLAS has put out ratings about the software for a long time, and there's no doubt that the software makes a difference. But we pulled together actually just two years ago. It was late November 2016. We emailed out to 10 of our friends and said, hey, what if we all, sorry, a couple months before that, we had done a quick poll, and it asked about 100 organizations, hey, have you measured the feedback of your end users about your EHR? And only 7% had done that.
Oh, wow.
So most of those, 4 of those percentage points were organizations that had recently come live on Epic, and Epic requires you to do a post-go live survey. So there's only like 3% of organizations that were doing this themselves out of their own choice, right? And so almost nobody was doing this. And at the same time, we're spending millions and millions of dollars on optimizations and a bunch of work. And so we said to 10 organizations, what if you all send out the same EHR satisfaction survey to all of your users? 5 of those organizations said, yeah, and they took us up on it. And we collected the feedback from those 5 organizations. And as it came back in, the feedback was so interesting. So we had 2 organizations that were using the same EHR. They were both using Epic. And the feedback was night and day difference. One was incredibly satisfied with it, and one had their physicians just screaming angry about their experience. And it was at that point that we said, okay, there's something really interesting here. 2 organizations using the same software, very different experiences. And so it started out as a benchmarking effort 2 years ago, where we helped organizations kind of benchmark against each other. Today, it's a collaborative, and we're working, I'd say, with some of the premier organizations, provider organizations, not just in the country, but in the world. And this survey that has been developed and continues to evolve has now been deployed at 154 organizations at 7 countries around the world. And we're really starting to learn a science of what drives success. And then what's almost more exciting than anything else is that we've got 63 this morning, ongoing members who have committed to measuring every year and or 18 months their experience. And we've now had 6 organizations that have remeasured their experiences. And for 5 of those 6 organizations saw improvements in their satisfaction, and 2 of them saw huge improvements in their satisfaction. So as we do this, we're starting to really learn what drives success. And those remeasurements, those are actually new since you saw our presentation at Chime. So we weren't even at a place where we could talk about those yet. So pretty exciting.
Yeah, one of the things you talked about in the presentation was this whole idea of a playbook. So one of the reasons that I think Epic has done potentially better than some other EMRs or EHR implementations out there is they have a very defined playbook. You do these things on these things, but one of the things you talked about is, just having the right playbook doesn't necessarily lead to overall success. In fact, you talked about a bunch of things that didn't necessarily correlate, that were potentially myths that we had grown to believe over the years.
Yeah, that's the problem with doing things but not measuring, is that you start kind of getting into ruts, and you get those ruts deeper and deeper, and you start thinking, hey, this makes all the difference. So let me give you an example of one of those ruts. There's just an assumption that if we put at the elbow trainers with people, it's going to make a big difference for them. Or if we give them voice recognition, it's going to make a big difference. And what we've learned is that you could actually dig yourself deeper into a hole by doing that. If you don't have a great trainer that goes and engages with those clinicians, so if you're not measuring, and if you deploy voice recognition in the wrong way, or even scribes in the wrong way, it's going to end up taking you the exact opposite direction. So you're going to put a bunch of time, energy, and money into making your EHR work better or your experience better, and it's going to be worse. On the Epic side, I think that this describes there's been a number of folks over the years and who have described Judy Faulkner and her approach and that team's approach to the EHR is, sometimes people would use a term, I've heard people use the term benevolently manipulative. So, they're kind of pushing us in ways to help us be successful with ourselves. And I'd give that a different term, change management. Epic understands in a lot of cases that change management is critical, and how do you incentivize human beings to make changes? And there's a whole science behind this, but Epic has done a lot of that. At the same time as we start to measure, we didn't have measurements for Epic organizations very much either, and we're starting to really learn that there's some things that make a huge difference, there's some things that don't make a huge difference. So it has been such a fun journey for us over the past 2 years.
Yeah, I can see that. Well, you threw up a handful of charts in the presentation that sort of struck me. And I think it was based on the question of, does the EHR enable high quality care, essentially? And then you had the response across 100 and I think at the time it was like 133 organizations. And the crazy thing was just the disbursement of that. And then you kept breaking it down. You said, well, maybe it correlates on the platform. And as you said before, there's an Epic implementation that has a lower percentile and there's one that's at the top percentile. You said, well, maybe it's academic medical centers, maybe it's children's hospitals. And you just kept breaking it down. Did that stuff surprise you? Give us a little feel into that those specific metrics on the EHR enabling quality care.
Yeah, let's touch about this, because we actually just worked with Chris Longhurst at UCSD and a number of other leaders in the ARCH Collaborative to submit a paper to the Journal of Applied Clinical Informatics. And we got a rejection, and I think we're going to resubmit. And one of the referees said, look, everybody knows it's the software. and the challenge that I have with that is that if the software was the key driver of success for an EHR implementation, and I'm not going to argue the other side that it doesn't matter, it matters. But if the software made or break were the make or break factor of success for your users, then we wouldn't see high variation within the customer base. We would see most Epic organizations scoring in about the same place, and most Cerner organizations, Athena, Allscripts, and Meditech, and down the road. But that's not what we see. We see this huge disbursement, as you say, and we see some Epic organizations scoring higher than some Cerner organizations, and vice versa. And we see this huge variation. We do see some EHR platforms that we have not really measured a successful user group yet. And so the EHR does make a difference. But the variation is very, very telling. So then you look at it from an organization standpoint, and you say, maybe it's the type of organization, maybe it's children's hospitals versus academic versus large versus community hospitals. And look, we found a successful type of organization of every type. And actually, the organization type doesn't make a big difference. We do find that organizations outside of the U.S. Tend to be a little bit more satisfied, but they can also be incredibly unsatisfied. So currently, the least satisfied organization that we've ever measured using Epic software is an organization that's outside the United States. So, there's just a lot of variation that goes into this, and really what it comes down to is, we believe that we're building checklists and learnings and things that are helping organizations focus on what matters most. But at the very end of the day, an EHR is a leadership test. It is a test of leadership and teamwork and joint effort and culture to be able to see if you can work together and make this thing work. And if you don't have the leadership in place and the teamwork and everything that you need to, then it's going to not work. And it doesn't mean that you can't improve your leadership, and it doesn't mean that you can't improve your teamwork. And a lot of times the insights from these users identify those opportunities.
Is there correlation with some of the things, as you threw them up there, I was wondering, is there a correlation with budget, the amount that a system budgets, or is there a correlation between size of the organization?
Okay, so hold on a little bit. It's not a statistically significant correlation, but organizations spending more tend to have slightly lower satisfaction. That's how the regression line lands right now. So it's slightly negative. Although we do see on the tail, there's a few organizations, if you're spending less than 3% of your operating budget on IT, you tend to have a little bit lower satisfaction. So there is a group that's really has really low satisfaction because they're just not putting enough resources into it. But by and large, there's a lot of organizations that are in the very same range in terms of how much they're putting into to their EHR and into IT, and they're getting very different results. We don't see your most satisfied type of organization in the United States is a multi-hospital community health system. So a health system of around 500 to 1,500 beds. That's going to be your most satisfied organization. But that's not worlds better than other organizations. But they tend to have a little bit more scale to be able to support things, but they also tend to be a little bit closer to some of their users to have some of the teamwork. But we've seen very large organizations be quite successful, and we've seen very small organizations be quite successful. But when it comes to investment, I don't think we should be very surprised. I shared this at I shared this when we were presenting at a time, I believe. But there's a great post from Nate Silver, the 538 website, and he talks about how, even in baseball, where we have so many statistics and so much data, baseball 30 years ago was really bad at spending more money and getting a higher win rate. And there was a very poor correlation, and it's gotten a little bit better in the last 30 years, which is kind of bad for the game, but we won't go there. But the bottom line is that this is hard stuff to do, to spend money in a way that's really going to make a difference, and which is why, look, if you go and measure with the Arch Collaborative or you measure with somebody else, just measure. Don't keep moving forward with what you're doing. And if the Arch Collaborative can help with anything, we would like it to become absolutely unacceptable, because we believe that it is unacceptable to move forward as an IT organization and not measure the feedback of your users. Because you just don't know what you're spending money on. It's a little bit reckless to not measure at this day and age, when any organization, even if you don't do it through us, could just build a survey monkey survey and send it out to your users and collect their feedback. This is just something that should be standard practice in the industry, and we think will dramatically improve the experience of clinicians using their EHR technology.
Yeah. Now, with that being said, there is a science to collecting that data, and we won't go into that, but essentially, there are good questions and bad questions. There's leading questions. But yes, you're right. It's easy to create a survey these days.
Well, let me share with you. Every organization, that's a great point, Bill. But now look, go to our website and steal our survey and put it in SurveyMonkey and do it. We don't care. What we really want to do is have you measure, or come to us and have us help do the measurement for almost no cost. At the end of the day, go do the measurement. And so, how I said that there's 3% of organizations that are doing their own surveying. We run into 1% of organizations that have longitudinally resurveyed. And every single one of those organizations, and there's 3 that we run into, they all, when we share with them our findings, they've all gone, yeah, that's exactly what we see also. So they've come to some of the very same truths and findings that everybody else has just by measuring their own organization over time, because they put in some of that effort. And I'm gonna throw in an extra word on that. They put in the effort and the courage, because it is a really scary thing. And I've had CIOs and CMIOs say to me, hey, do you realize that this is something that could make me lose my job? And by doing this measurement, and we've had others who've said in not quite as uncertain language, hey, there's kind of a scab forming over the frustration with the EHR from our clinicians. We'd rather not pull off that scab. And we hear that, and that's just like nails on a chalkboard for us. Because we know the truth of the matter is that there's not a scab forming over the frustration with the EHR. It's just that people have stopped coming to you because they don't see you as a problem solver anymore in your IT or informatics department. And that's just not acceptable for us to do that when we've got frontline care clinicians, caregivers who need to have the best tools possible to be able to be successful.
Yeah, it's interesting because healthcare is one of the few industries where we've applied significant technology and resources and data and analytics to it, and we get back that it's becoming less efficient. It's becoming more burdensome. It's not user friendly. We end up telling these stories. There are other industries where it's made all the difference in the world. I mean, you can do things that you couldn't do before. Now, true, there are a lot of those stories within the EHR. We can now find correlations across multiple populations, and we can identify things a lot better and those kind of things. But that's not what the physicians are experiencing. So do you, or the clinicians, so do you spend a lot of time on the clinicians' feelings and burnout and their use? Does that get covered a lot in the survey?
Yeah, Bill. And as you say, that's one thing that, because we haven't been measuring, we've taken as universal fact that in healthcare, there's a Russian word for it, Bobshay, just generalized across the board that this is just how it is, and it's not, because there's organizations that their clinicians report back to us extremely satisfied experiences with their EHR, and at those type of organizations, you have users who have really mastered how to use the EHR well. They have a great governance and communication structure where they're able to give feedback, and they love the EHR because it's able to adjust to be able to help them out. So when they need, they feel like they have a backstop and something that's helping them. And then they've learned that they're responsible for part of the success of their EHR. So they've had to personalize their experience. But a lot of those organizations are just happily doing what they're doing. And they don't know. I mean, everybody else is kind of whining. And I talked to one of the physicians that was from the highest satisfaction organization. So she had practiced, and then she had recently moved, and she was at a conference that I was speaking at. But she had been practicing in Oregon at Kaiser Permanente. Highest satisfaction group that we've measured among physicians. 92% of them report that their EHR enables them to deliver high quality care. And just getting 92% of physicians to agree on something, that means you're really doing a good job. And I said, this was just happenstance, and we talked about the frustration with EHRs. I had a slide up that talked about just general frustration with EHRs. She raised her hand and said, I don't get what this frustration is about. These things are amazing. They've helped us so much. And I said, can I ask you, and this was just dumb luck. I said, can I ask you, where have you practiced at? She said, I just came from Kaiser Permanente in Oregon. And I said, well, guess what? You're coming from the highest satisfaction organization. So she's not relating with her peers. And as they're talking and kind of nodding their heads and going, yeah, we hate EHRs. She's sitting there going, no, this is amazing. This has revolutionized the way that we practice medicine. And anyway, so just kind of an anecdote around some of this. But when you talk about burnout and some of the experiences that we're measuring on that, we've just started measuring burnout. We're using the single question burnout inventory from the American Medical Association. And what's interesting, whereas there's huge variation in EHR experience, variation in burnout by that measurement, and I know that there's others out there, so we've got to say what measurement we're using, but by that measurement, there's very little variation between different organizations. It's pretty steady. And so even just when you know that that the EHR success can't be that big of a driver of burnout because it's all over the board. We believe mathematically right now, I'm a statistician, we believe that about 10% of burnout is driven by the EHR. So organizations that have a better EHR satisfaction do have lower burnout, but it's only a reduction as you go to those lower ones, or a increase of 10% burnout where you have greater EHR satisfaction. We're still getting, yeah.
That's interesting. That's a lot lower than I would have guessed. Now, a lot of physicians are entrepreneurs. Entrepreneurs have a high burnout rate in and of themselves. The EHR typically gets a lot higher. I mean, you're saying 10%. That's fascinating. I think there's a regulatory burden that's hitting them. There's a documentation burden that's hitting them. So it would be interesting to get a good feel for. I mean, do you have a good feel for what the factors are for burnout?
Yeah.
Oh, you do. Okay.
And there's several groups. There's several groups that are researching this also. So there's the Stanford WellMD group, and I just had a call with them last week. Mayo has a group this measuring this. I just was emailing back and forth with them an hour ago, and then the American Medical Association is also measuring this. So there's multiple organizations measuring burnout. There's some others too, and as I've had conversations with all three of those groups, there is an agreement among these groups, and I don't want to speak for them, but I think that they'd be okay with me just saying this. I've had conversations with them that the EHR is a contributor. I think we all agree with that, and there is data that says that the EHR is a contributor. And in some organizations, it is a more significant contributor. But the greatest contributors to burnout include a chaotic work environment, include a lack of teamwork and shared values in the organization, and include too many bureaucratic tasks. And those tend to be your top 3 issues with burnout, followed by the EHR. So right now, I mean, there's not complete agreement between all of these groups that are measuring burnout, but that tends to be sort of the order that folks are putting the burnout challenges in. And I prefer to think about the EHR as sort of a magnifying glass. If you have poor teamwork and you've let your bureaucratic processes just go unchecked, because guess what? They're not the same for everybody, not even in the same state. Some organizations have a compliance department that has gone completely crazy. And some organizations have been able to have meaningful, real discussions about how to rope this in. And if you have worried about the work environment for your clinicians, if you're worrying about these things, you put an EHR over the top of that type of environment, it's going to be fantastic, probably. There's a few other factors involved. And one example of an organization I'll say is JPS Health System out of Texas. They have really, really high clinician fulfillment, high physician wellness, and really high EHR experience. And it's because they have some of the best teamwork we've ever observed in any of these organizations. And they have an incredible executive leadership team, and they do some things that are really outside the box in terms of how they approach things. So that's an example of an organization that you put an EHR over the top of. Then the EHR is just, of course, incredibly successful because you have really, really strong teamwork between different clinicians and the way that they're working together.
So you're building some of these best practices. So I'd like to dive into some of this stuff. So, gosh, we could talk about this for the next 3 hours. Of course, we only have like a 45-minute episode. So, one of the myths that I sort of propagated was that I don't know if this is a myth, but the day you're done your implementation is typically when you want to survey, because it's going to be the lowest satisfaction rate you're going to have. Because then you're going to start optimization, and every year after that, you should have increasing levels of satisfaction. But I think what I hear you saying is that's only true if you have certain things in place. So what are the organizations that score high versus the organizations that are scoring low? What do they have in place that leads them, as they're doing their optimization efforts, as they're investing, as they're increasing their focus on this? What are they doing that enables them to actually move their satisfaction into an upper percentile?
No, that's a great question. You're exactly right. So we see some organizations. So some of the most satisfied organizations that we've measured, I'll give you an example. Metro Health in Cleveland has had Epic for a really long time. I gave the example of Kaiser Permanente. They've had Epic for a long time. Memorial Health System has used Cerner for a lot of years. So some very long-term successful organizations that have just built up their success. What they've done at these organizations, I'm going to give kind of a high-level perspective and then dive down a little bit. What they've done is they have built real teamwork around the EHR. And what does that mean? That means that they've helped users realize that they're responsible for a piece of their success. And that's tough to do, to help them realize that they've got to do some things in order to be successful. That takes really good communication and persuasion, and that makes sure that when you sit down for a training engagement, you don't just say, well, here's how you use the EHR. You say, look, our goal today is to work together as a great team in our care processes. Our processes are embedded into our EHR. So when we're talking about today's training, we're not just talking about the EHR, we're talking about how to work together as a team. We're also talking about some things that you're going to have to put into place to be highly successful. And there's things that we can't do to make you successful. You have to do these things. So let's dig into it, right? Just that little tiny beginning at the beginning of training can make a world of difference as organizations are really capturing the hearts and minds of their folks. They also have in place really good communication networks. It shows up in different ways. Some groups are really good at doing rounding, and they are visiting their clinics and visiting their departments and talking to them about where they need to improve. Other organizations have so Memorial Health or Salford Royal in the UK, they have these IT centers where everybody can come in and get help, and they're centrally located, and they have in the UK they have coffee and tea and cake, to lure you in, right? So you can learn from them, or they come and engage you really well in their departmental meetings. We see that at some organizations. But however it is, there's this communication layer. And you feel like if you're a clinician at one of these organizations, that there's real caring people on the other side in informatics and IT that are trying to work with you to get to the best situation possible.
Yeah. So what you gave us 3 common negative EMR emotions. And I love this framework because you said, generally speaking, people using the EMR feel stupid. In other words, they don't know enough to really get their job done. They felt more effective before they had the EMR because they were the master. They understood how to get things done. So they feel stupid. They feel discomfort. Using the EMR sometimes to them feels like I just gave them a hand-me-down. Like, here's my brother's shirt, put it on. Yeah, it covers you. You're good. It's one size fits all kind of thing. But they feel there's discomfort. So stupidity, discomfort. And then the third you said was hopelessness, which is they just throw up their hands and say, there's nothing we can do. You just got to grin and bear it. We're just going to make it. So these are the 3 really deep emotions that you got from the survey. But I love the fact that the findings, from there, you could really build out what you need to do to address stupidity, discomfort, and hopelessness. Can you talk to the things that successful organizations have done to not have those negative emotions present?
No, that's great. Bill, you explained it better than I've tried to. So in order to not feel stupid, I need to be a master around the EHR. It's a core piece. There's a lot of studies. Stanford did a study showing that a majority of the time of my patient engagement is actually spent in the EHR. So the EHR is becoming something that I spend, half or more of my time in as a clinician or a physician, depending on my specialty. And so if you're now spending half of your time in a tool and you don't know the tool very well, you're going to hate your life. But the flip side of it is that organizations that do at least 6 to 10 hours of training for new physicians and 3 to 4 hours of training a year on the newest functionality, but even more than that, they have great trainers. So Deaconess Health System, their trainers can't get hired until they can teach their IT and informatics leadership something really cool, like how to barbecue, or how to cross stitch, or they have to be engaging and interesting, right? And they have to be able to capture your heart. So first, in order to not feel stupid, you have to create mastery. And we all know what a great teacher looks like. We've all had those in college and high school, and so you need to have those in place in an organization so that you don't have a bunch of physicians who are unhappy.
Does a clinician want to learn from another clinician, or are you more looking for a great trainer and storyteller and communicator? What do you look?
We've seen 6 organizations where they say that they have, and only 6, where they say that they have physicians that are doing the teaching. And at 4 of those organizations, they have really, really high satisfaction. At 2 of them, it's pretty mediocre. So I think that actually might be a fairly good split. A physician teaching a physician can be amazing, and sometimes it's not. And sometimes there's, I think physicians would say there's some of my colleagues that I would rather not be trapped in a room and have to listen to them for a few hours, and there's some of them that are going to be way better because they get me and they understand me. So at the end of the day, we also see other organizations. Mayo Clinic has participated in this, and we did a case study, a write-up on them. They had incredibly high training scores, and we came to them and said, who does your training? And they said, it's all non-clinicians, but for several months when they're onboarded, they have to go through and learn all of the clinical workflows, and essentially they have to come up to speed. They have to become educated about clinical workflows before they're allowed to be a trainer. And they said, so for us, it works great. So it's possible to either way. It's probably a little bit better to have clinicians teach clinicians, excluding the cost side of it, but you can be successful either way. It just has to be a great trainer. It has to be a great teacher. It has to be somebody who doesn't just tell you what you need to know. First, they tell you that they capture your heart and mind, and then they help you understand how this is going to be applicable to your life, and then they tell you what you need to know. So anyway, so that combats the feeling of I'm stupid when I use this. The second piece is this is kind of one size fits all. This isn't for me, and I present a lot out, and this is one of my favorite things to do, and steal it from me because it works really well and it communicates things really well. But I always say, hey, especially if I have a group of physicians in the room, I say, what technology works the very best for you? And I always see 10 people pull out their cell phones and hold them up, right? So I walk over to one of the physicians. I've done this a bunch of times. Walk over to one of the physicians. I say, can I see your cell phone? They pull it out. They hand it to me. And I say, can you unlock it for me? And then they get nervous, and it's great. And so then they unlock it, and I say, okay, this iPhone right here, mine is not an iPhone, but it always is an iPhone if it's a physician. I say, this iPhone right here, you say is the most usable piece of technology in your life. Yes. What would you grade this iPhone? Oh, I'd give it an A-. It's super usable. Okay, great. I'm now going to take your phone. I'm going to wipe out all of your personal preferences. I'm not going to delete anything. So all of your pictures, your emails, everything's going to be here. But I'm just going to put your apps in alphabetical order, and your lock screen is going to be default and all that sort of stuff. It's just going to all be default.
Does the person jump up and tackle you to make sure you don't do it?
Yeah, but that's the point, right? Is you want to see those personalizations are like sacred to you, right?
Yeah.
And they matter a lot. And you hate getting a new phone because you have to go put them back in. And I never, of course, erase it. But then I turn to them and I say, okay, let's say that I actually did that. How would you grade your phone for usability now? They say C-, D+, right? And then we say, look, you moved your phone from a C- or a D+ to an A- because of the effort that you put into it to set it up to make it work well for you. The same is true for the EHR. But Bill, I don't know if I said this out of chime, but guess what percentage of physicians have taken the time to set up their EHR? It's less than 40%. Yeah. And so of course they're walking around. They're all walking around saying, I'm being stuck with C- and D+ technology. And we go, oh my gosh. And over 95% of organizations, those who have taken the time to personalize their environment are dramatically more satisfied than those who haven't. And in the organizations where that's not true, they have a really problematic EHR. And so you need to look at the technology itself. And then lastly, the hopelessness comes. I'm not frustrated that I have clicks. It just comes because I walk into you as the IT and informatics guy or gal, and I say, hey, I'm really frustrated with this. And rather than find a real solution with me, they just say, I think that's kind of how it is. And rather than give me a real answer, they just tell me, well, sorry, tough, that's what it is. So your most successful organizations have put a lot of thought and effort into Brian, too, at Greater Hudson Valley Health System, their previous CIO, who's now their Chief Transformation Officer, that tells you a lot about who he is, said, look, there's only me and one other person in my department who can say no. Everybody else either has to fix the problem or escalate. And when your IT analyst and your front line has to either fix the problem or escalate, turns out that there's a lot of things that they can do to fix the problem. So they have a better problem-solving group, and they end up having better clinicians. They end up having better teamwork and better communication. So a lot of that rests on the shoulders of your IT and your informatics group. How good are you at solving your clinicians' problems and helping them make the technology work for them?
So that was great. So we have comfort, hope, and mastery are three things that you have found that really correlate. I found it interesting early on that you said scribes doesn't necessarily correlate, which that's interesting because we hear that all the time. Hey, it takes too much time. Give me a scribe and I'll be happy. But that's not necessarily the case.
Yes, scribes don't. We're still waiting for longitudinal data, but we don't see scribes in our cross-sectional data correlated with any higher EHR satisfaction or lower burnout, and which is interesting because you're putting a lot of investment into these scribes, and then those physicians report the same levels of burnout, and actually they report lower EHR satisfaction on an average, and so it really makes you scratch your head and you go, oh my gosh, this whole KLAS Arch collaborative survey is bunk because everybody knows that scribes make a difference, and here's the problem. Is that we forget the human element of everything that's going on. You've got somebody who's a bad user, who hasn't taken the time to really learn it, who isn't engaging and communicating well, and hasn't set things up well for them, and all you're doing is putting a Band-Aid over it. The scribes don't go in and tell you, one of the most painful parts for clinicians is getting data out of the EHR. Scribes do nothing to fix that. And in order to make that work, you still have to be a great user. You have to understand how to use it. And this is tough technology because healthcare is really complicated. And when God made us, he made us a little bit complicated. So that the software that runs this most complicated services industry that I think humankind has ever seen is going to end up being fairly complicated. It's going to take some work to be very, very competent in an EHR technology. Plus, processes in hospitals and billing and everything like that, it's complicated. So it's going to take some education to really be able to use this well. And a scribe is a Band-Aid. It's kind of like putting a Band-Aid over a broken bone. It's not going to do anything unless you solve the first piece. However, we see a few organizations that use it as an accelerator once they're in a good spot.
Well, and that's sort of where I was going is, you take a look at something like voice notes and those kind of things. And, as an IT guy, so I was a former CIO, people would come to me and say, hey, if you give me transcription, that's going to help. But in reality, all these investments in technology and scribes and whatnot, they're good. But
yeah, they're not bad.
They're not bad, but essentially what you're telling me is focus on the people side of it. Focus on change management. Focus on creating a culture that listens, a culture that's responsive, a culture that's collaborative in terms of making it better. Educate utilize physician builders to customize the system. Implement training in ways that people can receive it and people can digest it and make it a part of it. So you're looking for, ownership, personalization, mastery are the three things you talked about. And all of those things, none of those things were, hey, go do another, $3 million technology project on top of the EHR to make it better or even upgrade it. We need to stay current with upgrades, but at the end of the day, you can still have, something that's 3 versions behind, but if you have the right things in place, people are going to know how to use it, feel empowered to make changes and make it work for their workflow and for their patients. Is that capturing it?
No, Bill, that's exactly right. And that your best users when it comes to voice recognition technology have taken time to train their dragon, so to speak. I actually steal that phrase because we've added a new question on the collaborative survey that says, if you report really high satisfaction, it pops up and says, you report really high satisfaction. What are you doing that maybe your peers are not? And the most common answer is, I've taken time to set things up to my needs. And one recent response that I saw was, I trained my dragon. So, it's the same principles that end up making voice recognition successful. Mastery, right? And then setting it up well to use it, and then some good support and communication and empowerment from the IT department. And so these are principles, bedrock principles. Once we get, and it's the low-hanging fruit at almost every organization, once we get most organizations up to a place where we're really starting to fire and people are using the functionality that they have, now we're at a place that you can come in and layer on top artificial intelligence and clinical decision support and a lot of these, and natural language processing, a lot of these functionalities that are going to really be accelerators for the industry. That's going to be really exciting, but we can't do any of that until we have users that are up to where our current technology is. Most are not even using most of the functionality in their latest version, let alone these next generation pieces. And if you think that it's frustrating today because you don't know where to click and where buttons are, start adding on artificial intelligence over the top to start giving you predictive algorithms. And if you don't know why they're predicting that, then you're similar to a pilot that doesn't know the limits of his autopilot. Then you don't know how to use it, and you shouldn't use it at all if you don't know whether you can use it in rain or snow or fog, and when you can use it and when you can't. And there's times when you can't use autopilot. So similarly, we've just got to get our users up to a place that we can start to do some of the exciting things that we're all excited about. And then we can really revolutionize healthcare moving forward.
Are there, as we get close to closing this out, are there, a couple stories you would share in terms of just some things you've seen out in the industry and you go, man, they're just doing it right. That is, that's going to lead to a really successful implementation.
There's a lot of stories. Let me give you 2 right now. One is Biden Health. We haven't done a before and after measurement with Biden Health, but they, by their own admission, said, hey, we were in a really bad spot with our EHR, and nobody knew how to use it very well, and we had a lot of frustration around it. They did a big upgrade, but they used the upgrade as an event. And they said they went to all of their hospitals. So they're on the East Coast. They went to all of their hospitals, and their community hospitals. They don't employ almost any of their physicians. And they changed the bylaws of each individual hospital one at a time to say a part of having privileges at this hospital is being an expert on our technology in order to deliver quality care. And then part of changing that bylaws, they set expectations with everyone. And then, of course, they had to have CEO support doing this, right? They set expectations. Hey, we're going to retrain everybody. And then when they did their retraining, they had physicians do the retraining. And they said we had amazing training because we knew that if we were going to require this and change these bylaws, that now the pressure was on us to do great. So they had great training. We measured them, and their satisfaction was off the charts in terms of what they had done. They had worked with their people incredibly well. They had expected a lot out of their clinicians. And their clinicians, of course, rose to the challenge. These are some of the smartest people in the world. They rose to the challenge, and now they're able to have a baseline to go work on improving clinical outcomes in different areas and do some things. There's one other group that's really exciting, had recently come live with their first measurement. It was Ortho Virginia, a large group of orthopedics practices. By the way, orthopedics tends to be the lowest satisfaction specialty that we measure in the collaborative. And Ortho Virginia, H.C. Estenroder is their CMIO, and is really a fantastic leader, in my opinion, as I watched them, and they took their feedback, and they went from lower satisfaction, they jumped their satisfaction up from being one of the lowest satisfied Epic organizations to one of the very highest satisfied Epic organizations in their second survey. And as we talk to them about what they've done, we're still learning from them, but they've done a lot of training, a lot of working one-on-one with individuals to get there. They also use scribes, and but they were using scribes before, and they're using scribes now. But they have found ways to use their scribes not as band-aids, but as accelerators. So an interesting organization that shouldn't be successful because it's a bunch of orthopedic surgeons who typically are pretty unhappy, and now they're one of the most successful organizations that we've measured. And what do they do? It was a lot of teamwork, a lot of effort, and some really great leadership. So a couple organizations that we think identify and really show what this looks like.
That's fantastic. So so tell people how they can get more information on the ARCH Collaborative. And it's a collaborative, so people can become a part of it. They can join. It's on the KLASresearch.com site. But how can they get more information on this?
Look, it is super easy. Google ARCH Collaborative. It comes up with our website. There's a button on there down at the bottom that says, I want to know more. It emails us. We get in touch with you. There's a lot of organizations today that, we've gone in 2 years from an idea to 154 organizations doing the measurement. So that just tells you that it's not that hard, to be, if you were moving that fast. So come join in. We're just now instituting a cost. To date, we had been measuring most organizations for free. There's now a nominal cost to come and measure. At least that's going into effect early next year. And but this is not what this is high courage. It's not high cost to come in and participate. And then we have a conference this next year in May. We've got 62 ongoing members that are going to come together in Salt Lake City. Last year we had 50 organizations that came together, and they teach each other about their best practices. And I'm going to boast that we have some of the very best organizations in the country, premier health systems. And when I say premier, I mean that down to premier community health systems to large premier organizations. And that conference is just amazing. So some things that we're trying to do, but it is a collaborative where folks are working together to solve this problem.
Absolutely. And I think I saw your survey. Maybe it's not the complete survey, but I saw your survey actually out there. It's this public domain. People can.
Oh yeah, it's out there. Look, steal it, take it. The secret is not in the survey. The survey is something that we keep editing. The secret is in uncovering these principles and helping organizations learn from each other. Our goal is that in a few years, this collaborative is done because we figured this out as an industry, and everybody started measuring. And I don't know, maybe there's an ongoing measurement piece that we help people with. I don't know if that makes sense or not, but we want to solve the problem, and then KLAS and everybody else can go start working on the other problems that we have in healthcare, because we've got plenty. But let's solve this problem. So come get engaged right now. Come get involved with us, and let's all solve this together.
Absolutely. Well, great work. I know that Lee Milligan mentioned you, Amy Maneker mentioned you, and they were really highly excited about the work, and both encouraged me strongly to engage with you, and I'm glad that I did. Is there a way that people can follow you, maybe social media or another way?
Yeah, Taylor @KLAS is my Twitter handle, and I just was tweeting this morning about the ONC report that just came out, and so if you've listened to me for the last few minutes, you'll notice that we have some strong opinions. So KLAS is also on Twitter. If you just do a search, you'll see the KLAS, and then KLAS is tweeting all the time about the things that we're finding on the ARCH Collaborative. So So join us and come reach out to us with an email. Come talk to us.
Absolutely. Are you talking about the HHS ONC announcement to reduce the burden? Yeah, I thought about talking to you about that, but we didn't really want to dive into the news story today. But that's good. I mean, everybody seems to be coming at this challenge differently, and it's great. We'll need it all to make it work.
No, and we need some of the things that they're pushing. They continue to be kind of in the same trap that a lot of organizations are, where they think it's the software, which is where we were a couple years ago too. So it's understandable, but we're working. Don Rudlick it came to our summit before, so we're working to try to work with them and to help them see what we're learning, and we're trying to share with them some of our findings.
But Taylor, I mean, the number one thing I say to people is, okay, so if that's your mindset, what you're saying is if we put every health system on the same EMR across the entire world, we would solve these problems. And people look at me and go, probably not. I'm like, exactly. Yep. We still have, there's other challenges we need to solve. And you highlighted a lot of them in this show, which is great.
We're all just new at this. I guess as final closing comments, we're all just new at this. I mean, we've only had EHRs and really rolling these out for just a few years. So of course we have no idea how to do these really well. And we're all going to look back at the challenges that we had. And it's similar to when we invented the automobile, and it took us 50 years to really realize that we needed an interstate highway system to really see the value out of these automobiles, right? And driving an automobile on bumpy dirt roads was just only a little bit better, or maybe the same as a horse. So we're still kind of figuring out what do we need to really make these work. And it's not just exactly what we thought it was. It's going to be a little bit different, and we're learning all together.
Absolutely. All right. Well, that's how you can follow you, which is great. You can follow me on Twitter at the Patient CIO, the show at This Week in HIT. Our website is thisweekinhealthit.com, and shortcut to our YouTube channel, which is now up over 400 videos, is thisweekinhealthit.com/video. I'm trying to get that vanity URL with YouTube, but quite frankly, I'm busy with my day job, so I haven't had time to really pick that up. So thanks again for coming on. Please come back every Friday for more news, information, and commentary from industry influencers. That's all for now.